So good morning, everybody. Thanks very much for joining us. My name's Jenny Bowman and I'm one of the people presenting today's webinar. Before we begin though, I would like to acknowledge the Aboriginal people as the traditional owners of the lands that we are meeting on, and say that I'm on Awabakal country, and I'd like to pay my respects to elders past and present and future. So we're talking today about a Prevention Centre funded project where we looked at community managed organisations and their role in helping people with their physical health and wellbeing. Presenters are myself and a couple of my colleagues, Dr. Tara Clinton-McHarg and Dr. Caitlin Feely. So moving on, Joe. And we have the lovely Joe Ladder, who's a member of our team as well, who's changing slides for us. So yeah, thanks, Joe. So basically the work of the team here at Newcastle Uni is centred around improving the physical health of people living with a mental health condition. Why we do that is really because of statistics like you see here, that globally people who are living with a mental health condition have a reduced life expectancy of around 10 years, and in some countries it's more. In Australia, estimated to be between 12 and 16 years. So that is clearly a totally unacceptable inequity, and there's a major public health issue here that we need to address. Thanks, Joe. So we know that the biggest contributor to that kind of excess loss of life and the morbidity and mortality are those same chronic diseases that cause the whole population. They're our biggest causes of morbidity and mortality, so things like cardiovascular disease, respiratory diseases, cancers. We also know that some of the biggest factors contributing to those chronic diseases are potentially modifiable lifestyle behaviours. And so that means there's considerable scope for prevention if we can be helping people to improve their lifestyle behaviours and live more healthily. So in particular, to be helping people address their smoking, to be helping people eat healthily, and in particular perhaps things like more fruit and veg in their diets, to be helping people not consume alcohol at harmful levels, to be helping people get enough physical activity, and also interestingly to be helping people sleep better. So there's increasing evidence around sleep also as a risk factor, for chronic disease. So these are the things that the research of our group focuses on. Thanks, Joe. What we know so far from more than a decade, I guess, of trying to work in this area and do research is that absolutely people living with a mental health condition are interested in and wanting to improve their healthy lifestyle behaviours. Not only that, but when they are in touch with a whole range of support services to improve their mental wellbeing, they are also wanting and expecting support for their physical health as well, and especially around those risk behaviours that we focus on. And when offered support, people will take up that support and people will accept being linked in with a range of services to help them make behaviour change. So we know that this is an area people would like some help addressing. We also know from the literature so far and our own research that there are some sort of fairly simple tools and resources that can support health professionals and clinicians to provide what we call preventive care, so helping people change those health risk behaviours. So sometimes it's as simple as things like having a space in an electronic medical record where a clinician can record someone's risk behaviours and things that they might like to act to change, or reminders and prompts in such a system to actually ask those questions. But we also know that it's certainly not that simple, that this does involve often a change of practice and a change of culture, and that can take time. And it also requires policy, guidelines and leadership at many different levels. So like most complex behaviour change, we need to act at all levels really if we want to produce significant change. Thanks, Joe. So why community managed organisations? Well, firstly, because they're a really increasingly important provider of support to people with lived experience of a mental health condition. And in New South Wales alone, we know there are at least 78 different organisations providing support to people with a mental health condition. And they count for something like a quarter of the total mental health workforce in New South Wales, and that is growing all the time. So the opportunities for
We might have lost Jenny, or is it just me? Okay.
Yeah, we've lost Jen. Do you want to keep going, Katie?
Yeah, that's all right. So I think what Jenny was saying was that there's incredible potential for the CMO sector to be providing support to a large proportion of people with a mental health condition. And that support could include support around lifestyle behaviours, so a focus on smoking, nutrition, alcohol and physical activity. So CMOs are non-government organisations, so they might receive some support from government funding, but are largely non-government. They work alongside the traditional health system, so services like the government community mental health services, for instance. And they provide holistic, person-centred support. So the support provided is led by the people accessing the service to help people to achieve their goals and support their recovery. And the support provided is really diverse. So it includes a range of things, for instance, support in engaging employment, accommodation, a daily life assistance, and peer support as well. So really a diverse range of services. And some of the organisations include, for example, Flourish Australia, Near My National, Being, One Door, and New Horizons. I think we might have Jenny joining us back again, so I can hand back over.
You just need to unmute, Jen.
Yeah.
Sorry, thanks, Jo. Would you like to carry on, Katie?
No, that's all right. I'm happy to hand back over.
Thanks, Jo. So sorry about that, folks, technology. The CMO Connect project is what we're going to talk about, and basically we were looking at the potential for providing preventive care in community managed organisations. We had two main aims. So one was to really explore what the potential was for CMOs to be acting in this space, helping people with their preventive care issues. And the second was to see how CMOs might be assisted to provide this kind of care. So that meant having a look at some of the barriers and facilitators to care, some of people's expectations, and seeing if there were strategies that might be put in place to assist organisations, kind of provide more of this care. And not that organisations weren't already, but to varying degrees, we thought that that would be the case. So some of the characteristics, this is about prevention, and hence why we're obviously working with the Partnership Centre. It's about organisational change. So recognising that the barriers and facilitators here are going to be both at an individual level, and so the views and expectations of people with lived experience, as well as support workers in CMOs, for instance, but also are about the system around those organisations. And we wanted to make sure that we utilised a co-development process, and so that we did involve people who were accessing CMO services as consumers of that care, as well as staff and support workers and organisations themselves and the management. We were conscious of using a framework such as knowledge to action to kind of guide what we were doing. And so largely the steps that we took in the CMO Connect project align with some of those within the knowledge to action framework. So it's about understanding what the problem is, what the literature tells us is the problem, what's the gap as well between the knowledge that we do have and what is actually happening in practice. And so it was then exploring that within the context of CMOs specifically, so not thinking or assuming that what happens in another context will automatically apply here, but recognising we needed to have a look at that local context of CMOs. The work involved assessing some of the barriers and facilitators to preventive care being a bit more of a focus in CMO settings, and then working our way towards some developing of strategies and some testing of strategies that might actually help community managed organisations do this. Thanks, Jo. So we took an approach that was, I'm calling triangulated data collection, which basically just means that we tried to gather a range of different perspectives on the provision of preventive care in CMOs, and we used both quantitative and qualitative methods to look at current provision of care and to look at barriers and enablers or facilitators. So the perspectives that we covered included the managers, chief executive officers, included support staff, included people accessing CMOs, and included, I guess, a sub-study with peer workers, so people who were working as support staff within CMOs, but who brought their own lived experience to bear as well. And then lastly, the stage of co-developing some strategies that might actually help CMOs put this care into place. Thanks, Jo. And so, yeah, I'm going to tell you just a little bit about a couple of those different studies that were really focused on looking at the perspective, I guess, of the organisation and of managers in terms of what's happening now and what might we be able to do. And so we did that in a quantitative and a qualitative manner. There was an online survey of the CEOs of about 79 different CMOs in New South Wales. And there was a qualitative interview stage by phone of some of the senior managers. And one of the interesting things here, methodologically was it was quite difficult to actually discover who was the group of potential CMOs that we might be involving. And we certainly drew heavily on some partners in this research, and the Mental Health Coordinating Council, for instance, in particular, and the Way Ahead directory to help us work out who were the group of CMOs that we should be actually including. Thanks, Jo. So what we did find was that there was some preventive care happening around these kinds of health risk behaviours, but by and large it was happening in a fairly non-systematic way and not very comprehensively. So, for instance, some CMOs may have been happy to talk to people around something like smoking if that person actually raised and initiated that, or around physical activity, for instance, if someone had incurred an injury and it was stopping them, doing their normal walking, but may not have been proactively and kind of systematically asking folk about some of those lifestyle behaviours on a routine basis, and may not have been doing it comprehensively across all of the risk behaviours, or maybe across all of the steps that can be involved in preventive care. So we often talk about assessing and advising and referring, 2 A's and an R. So often people might be asked or have a conversation about one of those lifestyle behaviours, but then it may not go further to kind of providing advice and linking people with support, referring people for behaviour change. So we often found that it was a little bit hit and miss. Much more commonly, people were having some conversation, but very infrequently actually being connected with places for support. When support was provided within the CMO, it was very often around practical education and life skills, and meeting people where they were at, so going shopping with people and helping them buy some healthier groceries, etc. It was around providing some referral and connections And this is something that CMOs, I think, often say is an important part of their role, linking people in with other things in the community. And I guess it was generally providing encouragement and motivation that you can do something to address your lifestyle behaviours if you'd like to, and that there is support available. Thanks, Jo. So I'm going to stop now and I'm going to hand over to lovely Tara to talk to you for a little while.
Thanks, Jenny. So I guess the next part of the overall CMO project was we got all this valuable information from the organisations and the organisational leaders. And as Jenny mentioned, we did find from these that CMOs do offer some services to address the SNAP behaviours, but we really didn't know a lot about whether the staff were providing this support as part of their routine practice. And although the leaders of the organisation may have an overall view of what's happening, it's really important to ask the staff members themselves, get their perspective on what's happening in their day-to-day practice and for the support that they're providing. So for this first study where we were looking at provision of care provided by CMO staff, we wanted to see how frequently CMO staff members were actually addressing the SNAPS risk behaviours. So I'm putting the S on the end of the SNAPS for the sleep as part of their usual support to people with a lived experience of a mental health condition, and also to try and identify the strategies that were being most commonly used by CMS staff to address these behaviours. Thanks, Jo. So for this study, we used an online survey, and it was a survey of staff employed by CMOs in New South Wales. And the way that we accessed these staff was from the previous study with the organisational leaders. We were very nicely asked if they would help to facilitate some recruitment of their staff. 11 CMO leaders agreed to facilitate some recruitment, and that actually covered around about 1,400 staff members across these 11 organisations. Staff members were eligible if they were 18 years of age, they'd worked at the CMO for at least 4 months, so they had at least some experience with their the people they supported, and they also had to provide direct support. They had to be seeing people with a lived experience as part of their day-to-day routine. So from this, we were able to get 199 completed surveys from staff, and that averaged across CMOs at around about 45%, so just a little bit under a 50% response rate. The majority of people who took part in this survey were full-time staff members, permanent staff members, and peer workers, the people who use their lived experience in a meaningful way as part of their work, were about 13% of responders. So we found that the proportion of staff that said they were addressing a health risk behaviour at least once per week with the people they supported ranged from about 60% to 85%, which is quite high. So it's something that is occurring probably on a weekly basis for staff. But you can see that across the different SNAPS behaviours, it's not quite equal. So for smoking and alcohol, it's around about 60% of the time, whereas for nutrition and physical activity, they might be having conversations or addressing those types of risk behaviours a lot more frequently. And for sleep, it was a little bit kind of in the middle. But we did find that the median number of supports that people said they were addressing these risk behaviours range from about 15% to 48%, depending on the behaviour. So 15% for smoking, they might be having those conversations or support a lot less compared to maybe half the time for physical activity. Next. And so we also wanted to know what types of strategies that staff were using when they were supporting people with their risk behaviours. And we found that the types of strategies that staff were using most often, around 50 to 100% of the time, were discussing the health risk behaviour goals with their the people they supported, providing advice or suggestions around how to improve their risk behaviours, providing some resources, following up with them or reminding them about advice they'd been given previously about a risk behaviour, and also connecting them with their GP. But we did find that some of the strategies were used a lot less frequently, and these were really around connecting people with behaviour change support, which is a running theme through this project. So connecting the person with a support group, an information session, a different type of specialist, such as an OT or a sleep specialist, or with some type of telephone support service that might assist in behaviour change. These strategies were used a lot less frequently. So summing up, I guess, is the asking, the providing the advice, the resources, etc. is happening a lot, but the connection potentially isn't. Thanks, Jo. So to look at this a little bit more closely, we wanted to sort of see, well, why is that? Why maybe isn't some of the behaviours or strategies being used as well as others? And also we wanted to see if the actual risk behaviours themselves were having an impact on that. So we wanted to see how systematically the strategies were being used in terms of, were they using them with more than most of their clients or people they supported. So that's around about more than 80%. So this study aimed to identify the potential barriers that were being there to providing preventive care strategies, and also the associations between those barriers and the provision of care. So again, this study looked at CMO staff members. However, this one took place in one CMO, but it was a very large CMO. So it had 60 sites across New South Wales and Queensland, and staff members were once again invited to participate in an online survey. For this study, staff were eligible if they'd been employed for more than 2 months, provided direct care, and or managed people who provided direct care. To look at the types of things that might be acting as barriers or facilitators to providing preventive care, we took upon the theoretical domains framework, or the TDF. This is a well-known framework for all the different types of things that might affect a person's behaviour, the way they act, or what they do. And so in our context, it was around providing preventive care. So the types of things that might impact a CMO staff member's provision of care might be their own knowledge and skills, their own identity, what they think their role is, their beliefs about their own capabilities, whether they're able to do it or not, their optimism regarding whether they think that it's actually going to work if they have a conversation with somebody, will anything actually happen? Also, very importantly, their belief about consequences and whether they feel something like it might impact the relationship they have with a person. Things such as reinforcement, so whether they're being asked, did you do that today? What their intentions are when they go out to see somebody or provide support, the goals they have for their self and their work, whether they remember. This is just a really basic one. Sometimes people just forget. One of the domains which is quite large is the environmental context and resources. And this kind of feeds back to what Jenny was saying about, does your organisation have the kinds of policies and resources and management styles or things available that actually facilitate you to be able to do these kind of provide this type of care, as well as your social influences. So are the people you work with also doing what you're doing? Your own emotions and behavioural regulation. And this really can come into like how you feel about yourself and your own nutrition and your own physical activity. Should I really be telling somebody else to be active if I'm not active myself? Those kinds of things. So these are all the types of things that could come into play to somebody providing preventive care. Thanks, Jo. So for this study, we were able to get 190 CMO staff members to complete the survey. For this study, we actually had a majority who were female, and also a very high proportion of people had their own lived experience of a mental health condition, so around almost 60%. We found that when it came to providing systematic care to more than 80% of the people they saw, asking and providing advice happened the most often, except for alcohol consumption, which happened a lot less than the other behaviours. So I think only about 44% asked and 38% provided advice around alcohol consumption. We also found that for providing any type of connection, less than a third of staff reporting doing this for any risk behaviour. So again, much lower for connections. And the lowest for this was for smoking. Only around 17% reported providing any type of connection for quitting smoking, which we know is very critical for someone who wants to quit smoking. Support is very essential. Thanks, Jo. So overall, we found that the barriers that came out as being the largest to providing preventive care were behavioural regulation. So I guess, again, how you internalise or think about whether you can provide that type of care, your optimism around whether you believe that it will actually make a difference, and your own belief in your capabilities that you are able to provide this type of care. So this was really important information because it helps to know things that might assist CMO staff in the future. For example, if people don't think that the people they support want to change, they might be less likely to do this. However, if we have consumer voices that tell staff that they do want this and they do want to change, then that might help to impact the type of care provided. We found that for smoking, one of the things that was really lacking or coming up as a barrier was the knowledge and, was a facilitator was knowledge and skills. So that means if you had knowledge and skills around providing preventive care for smoking, you did it a lot. However, if you felt you didn't, that became a barrier. Another thing was reinforcement. So not having anybody really checking in on you or seeing if you're actually providing that type of care. And for physical activity, again, it was the behavioural regulation. So I think I've explained that before, but if you yourself maybe don't feel like you're in a position to tell somebody else what they need to do around physical activity, you might be less likely to provide that type of care. Okay, thanks, Jo.
All right, thanks so much, Tara. I'm going to talk now about a few of the next steps of the CMO Connect project. So the first study aimed to understand a little bit more about the role of peer workers in providing support for those SNAP behaviours. And this study was led by a member of our team, Lauren Gibson. So as Jenny mentioned before, peer workers are people employed to work from their personal lived experience of a mental health condition. So they bring this experience to their role, supporting people with a mental health condition to achieve their goals and through their recovery journey. They have an increasingly important role in mental health care. And so a recent workforce survey found that about 10% of the CMO workforce are peer workers. But there hasn't been much research exploring peer worker perspectives on how support for SNAP might form part of their routine or usual practice. So we conducted a qualitative study with peer workers of CMOs to explore how lifestyle support, or specifically support for those SNAP behaviours, might be factoring into what they're currently providing as part of their role. So one-on-one semi-structured interviews were undertaken with 11 peer workers working at a CMO, and then an inductive thematic analysis was performed by 2 independent coders. And so some of the key messages from those interviews are summarised on this slide here. Overall, lifestyle support was a key part of what peer workers were providing. However, it was a bit variable by behaviour. So peer workers mostly spoke about providing support for physical activity and nutrition, but less so for alcohol and smoking. It was often opportunistically provided. So as you can see here in the quote at the bottom of the slide, where one peer worker was talking about sitting down to have a cup of coffee with someone and how this provides an opportunity to also chat about healthy food choices. However, peer workers did note that it was not always systematically provided for all the people that they support. Lastly, the value of sharing lived experience was noted. So being able to help guide someone on their behaviour change journey and achieve their goals informed by one's own lived experience. So overall, this study really highlighted that lifestyle support is a valuable part of what peer workers are currently providing. However, there is scope for it to be more systematic. And so the next study explored the views of people with a lived experience of a mental health condition who are accessing CMOs. So it's incredibly important to understand the perspectives of people who are accessing these services, particularly to enable CMOs to provide support that's person-led, so that it's aligned with the needs and goals of the people that they support. So this study aimed to determine the prevalence of those SNAP behaviours among people accessing CMOs and their interest in changing those behaviours. We also looked at perceived expectation and acceptability of receiving preventive care from the CMO, and then actual receipt of preventive care. So this study was a telephone survey conducted with 153 people who had a lived experience of a mental health condition and were also accessing a CMO. And the survey was across 8 different CMOs in New South Wales. So we found that a large proportion of people accessing CMOs were not meeting Australian national guidelines or recommendations for each of the SNAP behaviours. So the most common was nutrition, where about 96% of people weren't eating the recommended amounts of fruit and veg. And the lowest was alcohol, but it was still around a third of people who were drinking more than the recommended amounts. So these levels are all higher than what we typically see in the general population. So for example, about 50% of people were current smokers, compared to around the 12 to 14% that we see in the general population. But on the flip side of this, if you click Joe, oh, they're not coming up. Oh, there we go. So of those who weren't meeting those national guidelines, they were also asked if they were interested in making any changes to that behaviour. So that's what you can see at the bottom of the slide underneath the pictures. So the proportion of people who were interested in making some changes. So you can see that for all the behaviours except for alcohol, over half of people were interested in changing their lifestyle behaviours. So really a high proportion. Thanks, Joe. So this slide here summarises the findings regarding expectation and acceptability of receiving preventive care from a CMO. In the 2 shades of green, so on the left-hand side of the figure, is the number of people who either agreed or strongly agreed with each of these items. So around 70% of people agreed that they expect to receive SNAP support from their CMO. And over 80% agreed that it would be acceptable to be asked about health behaviours, to be offered advice, and to be connected or referred to a support service. So really high proportions here. However, we also asked participants about their receipt of preventive care from their CMO. So the questions followed that ask or conversation, advice and referral framework. And we're asked of each of the behaviours. So you can see summarised in this table the proportion of people who said they received each element of care for each of the behaviours. And so what we see is that across the behaviours, conversation or asking about health behaviours is occurring most commonly. But for advice and referral, so these items are only asked of people who were not meeting national guidelines for a behaviour. And what we see is that less people were being offered advice to change, and receipt of referral was less so again. There were also some differences by behaviour. So overall, it looks like alcohol is less likely to be talked, advised and referred for. So overall, this really echoes the findings that Tara and Jenny were talking about earlier from the staff surveys, quite similar findings across the elements of care and behaviours, and a really strong message that people are wanting to receive preventive care from their CMO and they're interested in changing their behaviours, but some room to be increasing the number of people who are receiving preventive care. So the next step, based on the findings of all this work, was to co-develop and pilot with staff of a CMO some support strategies to build the capacity of staff to be providing preventive care. So this study was across 2 stages, so the first being a co-development activity and the second being a pilot. So in stage 1, we held 2 co-development workshops with staff and managers from one large CMO. 20 people participated across 2 sessions, so 2 workshops. In these workshops, staff provided feedback on potential support strategies that could assist them to deliver preventive care, and they discussed suggestions for how to best implement these strategies. The workshops used a nominal group technique, so participants firstly had a discussion and generated a list of strategies that they thought could be helpful, and then independently ranked the strategies, so from the ones that they thought would be most beneficial to least. And then a summary of those rankings and scores were presented back to the group, and they were able to discuss their overall priorities. And from this process, on the right-hand side here, you can see a summary of 3 of the key strategies that came out of this activity. So firstly, training, particularly around conversation skills, as well as motivational interviewing. And this was ranked as highest in both the workshops. Practical step-by-step guides for how to provide preventive care with a strengths-based focus was also recommended. And lastly, connections guides, so something that outlines what are the available referral services in the area, with a focus on ones that are free or very affordable, that staff could be connecting the people they support to. And so the next stage of this project was a pilot of these co-developed strategies with one CMO. This was a controlled before and after study. So we had 2 sites of that one CMO, one that received the intervention and one that was a control site that continued their usual practice. The main outcomes of this pilot trial are around staff report, so staff reporting their ability to provide preventive care and also their care provision. Our analysis of the outcomes of this pilot trial are still underway at the moment, so I'll just focus on the impact of the training component specifically, so that first strategy that was recommended in the workshops. So this slide here gives a little bit of a summary of the training that was provided. So the training was called the Healthy Conversation Skills Training. It has been used in other health settings before, and it adopts a person-centred approach to behaviour change. It really aims to enhance health professionals' communication skills and ability to empower people in health behaviour change. In our intervention, 16 CMO staff received the Healthy Conversations training, and staff completed a survey before and immediately after the training. And at each time, they rated their confidence and perceived importance of providing support for the SNAP behaviours. And what we found was a nice increase in those ratings of confidence and importance. Competence was also measured using open-ended questions. So people who received the training are given a hypothetical scenario, and then they are asked to write down what their verbal response would be in that scenario. And there's an existing framework as part of the training that allows coding of those responses. And so looking at the responses of staff in our pilot, we can see increases in competence in providing preventive care. So as I mentioned, we're still currently finalising the analysis for this trial as a whole to consider the impact of all the strategies, and preparing 2 publications. So one that describes the workshop process themselves, and then another on the pilot outcomes. And I now hand back to Jenny to talk a little bit more about the implications.
Thanks so much, Katie and Tara. So I think we're just conscious of time. So from the CMO Connect project, we've been enabled to do a couple of other things along the way. So one was a rapid review for the New South Wales Ministry of Health around initiatives to improve physical health for people who are accessing CMOs. And the second is a bibliometric review that we've got underway at the moment to look at the broader role of peer workers who bring their own lived experience in supporting people around their physical health kind of needs. So those things are a work in progress. So overall, what do we think we kind of found? So certainly I think we found that our research confirmed the potential role and an important role of CMOs in this area. We have an improved understanding of current practice from multiple perspectives and of the barriers and facilitators, and things that might actually help preventive care be more integrated into CMO practice. We have had an opportunity to sit down with a CMO to talk about things that might help support workers in this space and be useful. And we're, as Katie said, currently still kind of looking to see if those strategies did indeed seem to help people. The future, clearly, I feel like we're just scratching the surface here and would like to do more work with community managed organisations in this area. For instance, around the kinds of strategies that have already been developed, a rigorous trial of those to see if they make a difference to people's practice, and to be able to scale then and maintain strategies that are found to be effective. I will say that the future looks bright, I think, as well for practice and research, because we have developments like the Equally Well kind of alliance in Australia that's really a large group, brings a lot of key stakeholders together nationwide who are really vested in improving the physical health of people with mental health conditions. So I think the future looks bright. Thanks, Jo. I think some of the implications for the sector, we did get feedback, particularly from the work with managers and CEOs, but also, I guess, from broader conversations with people involved in the sector, that there needs to be some acknowledgement that delivering preventive care may require some different resources and some of its dedicated funding to CMOs, if at all possible, and be recognised as something CMOs could be doing and have expertise to do in things like the funding agreements and models. The support workers in CMOs require some training and resourcing if they're to do this. There's so much of it already happening, but a demand for more support. And as we found, that can be as simple as, yet it's not really simple, helping people feel confident to start conversations with the people they're supporting, and to know that this will be a welcome conversation if it's kind of done in a sensitive and person-centred manner. How important co-design and co-development is here, to understand that if strategies are to be effective and taken up, they really have to seem sensible to all key stakeholders here, and to recognise the organisational diversity and that these organisations are providing care for people with quite complex mental health issues. Lastly, I think integration. So with other parts of the mental health system. So I think, it's often the same people who are accessing support from CMOs as they are from other government services and community mental health services and inpatient settings, etc. And it would be ideal if there could be some integrated effort across those different sectors to improve people's access to preventive care, as well as across the CMO sector. And I think there are so many great organisations out there many of whom are already investing a lot in this space and doing good work. And I think it would be fantastic if could be an effort to bring together the sector more so, to be sharing knowledge and resources and skills in this space. So I think I wanted to finish there. There's some of our publications that are already out at the moment, and we hope there are a few more in the works. And I'm sure these slides could be shared with folk later if you wanted to have a look at these. Thanks, Jo. And I wanted to finish with some really important acknowledgements. So absolutely the Prevention Centre funding, which allowed us to undertake this work, but also critically, obviously, community managed organisations across the state, people who were working in those organisations, including peer workers, and people accessing those organisations who all contributed, their time and energy to our data collection. There's a special thank you to Flourish Australia. It was a Flourish Australia service who's taking part with us in this last kind of development of strategies and pilot stage. And I would particularly like to give a shout out to the Mental Health Coordinating Council, and particularly Corinne and the Mental Health Commission of New South Wales, who really offered us invaluable support and expertise along the way. We'll stop now, and I think we are going to look to see if anyone has some questions. So I can see a lovely comment from Sarah. Thank you. So is there anyone online perhaps who's from a community managed organisation who wants to reflect on some of this and perhaps what's left to do, or some of the things we didn't do? What are the gaps in what we did and what would be good to do next? I think we have some of our NEMI national friends online.
Okay, so here's a question.
Hi.
Yep.
Hi.
So I'm sorry.
This is Vicky Langan from NEMI National.
Hi, Vicky. How are you?
I'm good, thank you. Good. Great to see the presentation. Thanks, guys. And we're very excited about this. And just one thing that I've been really thinking about over the past while is, and I've really noticed it, is that, and you mentioned it at the very start there, is that we all seem to be working in silo, doing our own thing. And actually what doesn't exist is a network of CMOs, especially around physical health. So, you know, I actually have approached MHCC and Corinne to talk about that. And I think that might be a really good next step, is that if we all come together, sit down and at the table together and see what we're actually doing and share each other's resources, share each other's ideas. And as we said, then we can, you know, work together and I suppose, you know, because we're all trying to do the same thing. And if one program is working really well, why not adapt that in another organization? So I'm very enthused to do that. And if there's any other CMOs a bit around listening, I'm very happy to lead that network, if you know. So let's get that moving.
That's just fantastic, Vicky. I'm sure there are people with similar thoughts, and you know, we are researchers, but I'd love to kind of be involved in that too if it gets up and happens. I'm sure there's some great, you know, research we could all do in that space as well. So thank you very much. I'm just noticing a comment there from Andrew about, doing this work within the COVID context. And I didn't mention that, but probably should have, because that was absolutely a major challenge for everyone who was taking part in this with us. Absolutely, no doubt, you know, at different times across the state, in and out of lockdowns, and providing care that was less face-to-face and much more, you know, via other means. And certainly as researchers, we had to adapt as we went along as well. We were fortunate, I think, very fortunate, that this was research that by and large did still happen, did keep going, although we were slowed down, I think. Hence, I feel like we've dragged the chain a little bit getting some of our outputs out at the end. But I think we were very fortunate too, and really glad that, people stuck with us, because, things slowed down a little bit.
So there's a couple of other questions on the chat here, Jenny.
So someone's asked, was there resistance from staff or peer workers or anyone? Resistance, I don't think so. I mean, not at all, I would say, not resistance. I think one of the consensus findings, and from all of the key stakeholder groups involved, was how important this area is and that it has been neglected, and people were very happy that the work was happening and to be talking to us. Yeah, so no, resistance, no. I would really acknowledge in our work and the field generally, we certainly need to do more to gather the perspective and include the perspective of people with lived experience. That was perhaps the hardest part here for us to do, and we were very conscious of the ask we're putting on people to take part, but how important that is to probably actually do more of. Yeah.
One as well.
The co-benefits for peer support staff. So Lucy, we haven't, but that would be a fantastic thing to do. In fact, more work with peer workers in general in the community managed organisation setting, but also in some government mental health services, is an area we want to do much more in, and Katie in particular has got a real interest in that, and I totally expect there would be mutual benefit in that work. I'm sure there would, and we would love to, do some more qualitative work, I think, with peer workers to explore that kind of angle a little bit further.
Someone says they've been multitasking, so they're sorry if they're asking something that we've already said. Scope to see impact of homelessness versus engagement, or how much this impacts holistic approach.
So that's an excellent question. We didn't have information really on people's kind of living circumstances and whether or not people were homeless. But that's a great question and thing to raise, because I'm sure it does have an impact on people's just capacity, to address healthy lifestyle behaviours when they're homeless, when they've got, issues of putting a safe, roof over their head, or maybe, just not able to access the same supports in the community because they're homeless. And I'm sure that group of people will have quite special needs as well. Yeah.
So there's a couple of comments have come through, one from Elizabeth Story at the Mental Health Commission in New South Wales, with a bit of info about some peer work research happening.
Fantastic.
Thank you. And then also Jennifer Humphrey, who is keen to collaborate too, works at the Ministry of Health. So Jennifer, we will write your name down.
So I think we caught up with Jennifer just recently.
Right.
Was it last week or the week before? Yeah.
Okay.
But thanks. So definitely a contact that we hope to continue, Jennifer. So thank you. And hi, Lucy. You're welcome. We're obviously very grateful to the Prevention Centre for funding this work. So we really hope that it continues on and can make a difference.